Uh, we're going to demonstrate the robotic placement of both screws and the lateral cage. We're going to do it at L3-4. I'm joined with Zach, one of the SSF fellows here, who's going to be converted to a robotic surgeon at the end of this session, despite Rod's best attempts. So. All right, well, so you've learned a lot about kind of prone lateral, and the way I typically kind of do it is through the prone approach from the ways we've discussed. But we have really a nice single position surgery with the patient in the decubitus position here, and a lot of folks have done it this way, and this is a nice way to avoid a flip as well. And all of the things we talked about with the robot with respect to avoiding a flip, minimizing radiation, improved accuracy, and just removing that mental bandwidth, you're going to see today. You're going to see that demonstrated today.
Hey, so the robot... Can you hear us? Just tell us, just go back just for a second about lateral position, navigation and robotics, and prone position navigation and robotics. Any special issues between those two, or anything that stands out?
Yeah, it's such a good point. Thank you, Bill. So the thing, when you have a decubitously positioned patient, the issue is really the usual way of taping them down and fixing them to the bed. You can use the bump underneath the ribs just to kind of get a little bit of correction so they don't sag. I would bend the bed just a little bit, but definitely not like the way we used to do. But that was it. And the placement of our, obviously you need a reference frame to be attached to the patient, so that acts as a reference marker for the navigation. So, I select the posterior PSIS kind of position. I do that for both. They have this thing here, a surveillance marker, which is neat because basically, if there is if you like, skive or distraction of the reference base with respect to the spine, it should pick that up. So typically I put the surveillance marker on the other side. I keep it a little bit distance away here because it's just easier for the camera to pick up the reference frame. You can put it next to it. In the prone position, it's a little bit of a different deal. You really, really need to, the patient isn't just prone. They need to be as secure to the bed as possible without the risk of kind of moving back and forward. And that's, for one thing, that's because of having, if you like, the instrumentation work in the disc space, either the cob or the trials, or even ultimately kind of the box cut, or whatever it is before the implant. It tends to move the spine away from you, and that impacts navigation a little bit. But most importantly, if you have a fixed retractor and the retractor is fixed to the table with an attachment arm, it can cause some creep for muscle to come in. So for me, I know the different kind of vendors have different systems. The ATEC system is the patient positioner. I've just tended to use tape and really taped around the patient, both the hip and the chest. And I've tended to put a bolster or two, regular orthopedic style pads that you can keep in place. But there are patient positioners out there that do that for you, and they're able to really secure the patient down. So it doesn't change the necessity to kind of have a secure place for the navigation, which in this case, again, is the PSIS. But it impact. You want the retractor to approximate or move with the spine as much as possible. Part of that is having a shim as well, which allows you to do that. And there are nuances to it. So it's actually, I think, for me, in my hands, prone has become easier to do than lateral decubitus. But in this case, we'll demonstrate it through lateral decubitus, and that'll be a good kind of approximation of what you can achieve with the robot as well. Okay, so what's happened here is that we've positioned the patient lateral. So this is caudal, this side is cranial. The reference frame is in the PSIS, and there's a surveillance marker here too. I don't know if you can see it, but there's a little kind of spot on the screen there that indicates to you if there is movement of the patient away. So there it is. So I'm pushing on the back of the patient, and it basically tells you that there's movement of the spine with respect to the reference frame there. And so what's happened is that the preoperative CT, which has been acquired on this patient, has been already registered to a intraoperative fluoroscopy. And that happens inside the operating room. For me, that's a nice workflow. I prefer that over capturing intraoperative CT, like through a brain lab or an O-arm. And all that registration has been done for us already. So we're registered, we're ready to go. A couple of things I want to kind of point out before we move on. So this is the Globus robot. And basically, when we go to plan, we've already planned this out. But let's say that you wanted to look at the L3 screw. So this is the L3 screw on the left there. And here you've got the screw already marked out for you. You have the ability to kind of move the screw around, back and forward, up and down. You know, the surgeon has the ability to make an intraoperative change to the pre-planning of the navigation for the robot. And that may be very useful for situations where, for example, the incision is prohibitive to get to where you want, particularly in open incisions. John Askar made the point before that percutaneous is easier. And so, you know, this has been planned out already. Here's the L3 left. This is the L3 right screw. I have the ability, given that this patient is in decubitus position, to make this downside screw a little bit more medial to lateral, a little bit more straight in, as opposed to very much lateral to medial.
Let me ask you another question. So yeah, I found one of the problems with a percutaneous robotic screw, we talked about skiving before, is the entry point is the same as your angle. So the entry point on the skin becomes really, really important rather than just planning the screw from that. So what you're saying is lateral position, you will change and you'll mark the entry point on the skin differently than you will in the not the dependent, in the superior screw. And you'll plan that differently to look at it to allow you to compensate for that.
Yeah, I think that's such a good point here. The skive is such an issue that ideally I would love it to be in the same position, you know, between the transverse process and the facet. But the problem I have when I position them decubitus is that downside screw is there is almost a risk of collision with the edge of the bed there. So I want them to be as far back in the bed as possible. And so for the reason that you mentioned, I alter the trajectory a little bit. So I'm able to kind of do that. I don't know if you can kind of see this, but, you know, I make it a little bit more straight in. This it actually should be the left side like this, because we're left side down here. So I make it more straight in. But I don't want it to be so far back that when I do, for example, an anterior to psoas, pre-psoas approach, that the patient is too far away from me. So it's a little bit of a balance with respect to what we do. But the point is that I have the ability to change my plan, particularly when it's open.
Have you ever tried having them a little over lateralized, where they're bent forward a little bit, so you can kind of come in and do the downside screws a little easier? So not as a true lateral, but having them going over an extra 5 degrees, because your navigation will accommodate for that. That usually will give you a little bit better access to the downside screws.
Yeah, I think so. I think that's a really good point. Whatever it takes for me to be able to get them in and not have collision with a bed, and at the same time not be so low down that it becomes a difficult trajectory. Remember, the robot has to, you know, it's got fiducial markers or light-sensitive markers that it needs to see the camera. So in the case of this robot, there are markers both on the reference frame, there's markers on the tools, and there's markers on the arm and the end effector attached to the arm. So that triangulates a very sort of secure position with that. So to your point, you can make that adjustment.
Yeah, I think that just speaks to positioning the patient beforehand, and how you set the person up is a critical piece, because I'll move that person all the way over to the edge of the bed so that I don't have that getting in the way when I start.
Right. I thought you were a prone convert like me, Bill, so I'm surprised you're doing these, but yeah.
That's how I used to do it.
Yeah, exactly. There you go. So I think, we've done the registration already. You can see the plans already. What's nice, guys, is that we're going to do 3-4. And when I click on the 3-4 interbody, I can kind of see we've already planned it out so it's within the disk space. And, we have the ability to have a look. I don't know, hopefully there's less glare on the screen here, but.
We can see it fine. It looks good.
Yeah, there it is there. So, this is where robotics has come. It's not just screw placements, interbodies, and there's probably more to come. Okay, and with that too, you can kind of see what the dimensions of what we've picked. We've picked a 45 length implant that's 18 wide. Normally I try to do a little bit more, try to do a 22. That's
so let me ask you, sorry, another question, keep interrupting. I don't usually plan the interbody. What I plan is the entry point for the first K-wire and the dilator. Do you plan that first, or do you plan the where you want to put the cage, just sort of looking at it?
Right, such a good point. So because I do this prone, I tend to use the navigated dilator, and you'll see it. This is the navigated dilator here, and it allows for the K-wire to be passed through it. So I position this as posterior in the disk space as I'm allowed to with neuromonitoring, as neuromonitoring allows me, and I pass a K-wire down through that. That almost acts, it should be the back, the posterior part of the implant is where I want to dock it, and then I use a 3-blade retractor, so I'm able to open up all the blades anteriorly to then fit the implant according to the plan that I've made. The issue that I have with using the K-wire in the middle of the implant or wherever is that, especially in the prone position, everything wants to drag you down, right? Gravity wants to work kind of against you. So I mentally make a decision to approximate and to plant my K-wire as posterior as possible to account for this gravitational shift down. And then, remember, I'm docking with this in my ideal position, then opening the retractor. I like to use a shim. That's my preference. I know some people don't. I know with some of the systems out there, you have a 2-blade retractor and you have the option of a shim both anterior and posterior. So for me, that's what's nice. But your point is taken, and I think that if you have the ability to navigate it, and if nothing else, when you do put the implant in, you can see how far off you are from the plan that you've made. So I like that. Okay, so we've registered, so let's get on and put some screws in. So I'm going to start with the upside screw. So this is the right-sided L3, and there's a pedal here that we press. The robot is green. Green means that the camera can see both the optics here as well as on the dynamic reference frame. We press this button. I don't know if you can see it, but it's a convenient button here. And here we go. Can you see the robot move? We're starting at L3, so this is the upper screw here. All right, we got a satisfying noise to tell us that we're in spot. I just use a marking pen, Bill, just to mark out my spot here. I do the same for the next screw down on the same side. They've slowed the software down for us today, but sometimes it goes a little faster, I think, with a software upgrade. Okay, satisfying noise again. Same thing, I kind of mark it there in the middle of that, down that end effector tube there. Then I'm able to kind of move it away. Now, for time's purpose, we've done the other side already, so move the robot away. I don't know if you can see this or not, but here's my entry point for the L3. Here's L4. Mark across there like this. And let's have a blade here. So go down. I've opened up. I make a little bit more room because obviously I'm going to pass a rod down here, and I'm going to use an introducer to do that. And I get down to the fascia, and then I'm able to go through the fascia either with a bovie or with a knife, and that's where I stop. And furthermore, you're going to see a little trick with a knife when we get down to the spot. Okay, so we're back there. I bring the robot kind of back into the field. Right side at L3, press the button. Hopefully that'll take us to the exact same spot that we selected before. And it's moving. Soon you'll hear the satisfying sound and the green blade. So, Zach, why don't you do this? I want you to put this down the end effector. So that'll open up the fascia for you, straight down in there through the skin incision. And we can, yep, excellent. All the way down through the fascia. And then once you're through, you just want to, oops, not too vigorous on, because, you know, we've taped the patient out. Perfect. Okay, come on out. And I'll take that for you. Then let's give him the perforator. So this is the perforator to make a little opening in the bone. And what I do now is we pass this. I have the option of pressing the pedal again to recalibrate me, but I trust it. And then if you look at the screen there, you know, you can see, so Zach, if you have a look up there, that's you there. So go down all the way down to the bone. And once you're docking on the bone there, you back off 1 millimeter. There we go. You make a micro adjustment too. So you may want to just go lateral just a little bit there, like this. And then go ahead and make a kind of entry point with this. What's that? Okay. Did you make a? I'm going to test this. There we go. Very nice. And then let's have the drill. Excellent. So this will kind of distance out at the 30 mark. So there we are there. If you have a look at the screen there, there's the tip. The crosshair marks the tip of your drill. That's it. So back off 1 millimeter away from the bone again. So come back 1 millimeter. That's it. And then drill and go all the way down. Straight in. Very nice. Nice job. And just past the pedicle. There you go. Beautiful. And that's it. Come on out.
Noojan, quick question. On the bottom right, it says deflection. How do you interpret that?
Right. So I think every time you use an instrument, you're going to get a little bit of a deflection. It's basically a force meter, right? So it gives you some kind of indication of how much force you're putting on there. I tend to not pay too much attention to it because it's very temporary. It's a transitory thing. Now, before you use the screw, Zach, I'm going to recalibrate us there. And there it is. There's a robot again, recalibrating our point there. All the way down. It'll take us again, and you'll see the green outline, which will tell you that you're in position again. So perfect. So you are ready to place the screw in. And again, it's able to look at the navigation on the implement, on the end effector of the arm, of the robotic arm. Your assistant will just pull the skin back for you. Go ahead and push it in. That's it. And again, if you look there you are. There's the yellow screw. And go ahead, and you're on clockwise, I take it. Just going to make sure that, yep, you're good to roll. So, and hopefully you've got some purchase there, a little bit of bone bark, as we call it, you know. And there it is. You can hear the bone barking. Very nice.
Did you say bone barking?
Bone bark, like the noise of the bone, you know, like a dog making a...
Okay. That's what you want.
You learn these things from, and then you pull this
I always
back.
learn something new every day.
That's it. We're going to use that word. We're going to hear that word at Cedars pretty soon, I'm sure. That's it. So there's your screw in there. Okay, very nice. And then I just press the collar. I bring the robot out. I have to click on the, thanks, Zach, that was awesome. Click on the thing again, and he's got it in a very nice position. I'll just speed it up for 4 on the right. Let's go again there, and there it is there. It takes you straight to the entry point for L4. On the right, there's our green. Okay, knife again, please. Perfect, I got it. Straight down the end effector. I'm on bone. This is all a matter of seconds, right? So see, there I am, guys, on the axial. You can see me there. Back a millimeter. Next one. We're at 12 seconds so far. 20 seconds. Let's re-register, recalibrate the robot. It still likes me because it's green. Normally I'd make my incision a little bit longer than that. Very nice, thank you. I'm good, I think, yeah. Thanks, Vance. I could make a micro adjustment like that. Do you hear that noise that it made? It kind of told you that you were slightly off target there, but it's still pretty good. And then the other thing I didn't point out was that there was a check mark. See that green check mark? So when you go down to almost the intended level that you planned, it tells you, and there's a check mark there. It tells you to stop because you can keep going with the screw, and then it makes it too difficult for the towers of these perk screws to be able to move. So when you need to move these screws, it's hard. Okay, so there's that. Let's just do the downside screws real quick because I want to demonstrate that medial to lateral. So here we are. It'll take me to the other side. I've already done the incision. Look at that. Okay, I'm going to stop here. So, yeah, so here's the issue. It's too lateral to medial, right? So I can go to plan. It's on the left side. I'm going to make this more medial, more straight in. Do you see how I did that? That's okay. Back to navigate. Press the robot again. It makes its adjustment. Look at that. You know, intraoperative change in plan. My incision is okay. I'll take the black knife back through here. I'm on the bone, so I'm good. Thank you. Thanks, man. Yeah. I'll get an Army Navy or something. And then hand away for a second because it's going to look, yeah. There's my bone, so. Next one, thank you. So my point is that you can get facile with this, and whether you do it decubitus or you do it prone, this should be the, thank you, this should be the least mentally, you know, occupying part of the operation with respect to your mental bandwidth. Thanks. Awesome.
So once you put this screw in, just give us, I think we've got 5 more minutes, 2 more minutes?
2 more minutes.
2 more minutes. Tell us quickly how you're going to use the robot in the lateral piece of this.
We only got 2 more minutes?
We only have 2 minutes. That's all we've got.
Well, you know, let me, in that case, Bill, let me just get on to that real quick, right? So basically with navigation, I'm able to go down and mark out, get an idea. There's a little bit of tip extension here, right? So here's my 3/4 disc space. I don't know if you can kind of see it or not there. There's the back of my kind of disc incision. Here's kind of the front there. Can you see that on the axial there?
Yes.
Right there. Basically, I'm able to come down. If we have a second, I can put the retractor down and show you. But let's have the knife, the 10 blade again.
That's fine.
Yeah.
Keep going.
So then you're using it for identification of where you're making your incision, trajectory, and length of incision.
Absolutely.
And then you're using navigation to place.
I'm using navigation to kind of show me exactly where I'm going to dock. And I just want to show you where I would dock with respect to the dilators.
Yeah, so we put down a ghost down there, and then we use the navigation to then, just like a pedicle screw, to track down and put the dilator in the same place as that ghost image that we see. And sometimes I just use a long pedicle screw or a line or something.
Exactly. And I think that in this case, you have the ability to pre-plan it.
Go ahead.
You don't need to, I'm in the retroperitoneum. So for example, if I take that first dilator, it's connected to neuromonitoring, right? But let's say that I'm able to go down. Here I am. Here's the tip of my dilator. This is the first dilator. There it is. There's the disc space right there. Okay, and look, I'm aiming for the posterior part right there of where my implant would be. So right there. So I pass a K-wire.
Yeah, so then you're sort of combining navigation and robotics.
Yeah.
Well, you got a question? We had something.
No, the comment I was going to make was I do it very similarly. The one thing I do is, again, here it's a great example of how well you can see the soft tissues.
And I dilate.
And so I'll use the soft tissue windows here to assess the trajectory I'm going to go in.
That's what I do too. Yeah, so I usually use it for planning and knowing where you're at and figuring out what your exact angle is. Especially, I find if you're prone, you tend to go superior to inferior a little bit, and it's nice to stay flat. The other thing that's nice too is if you rotate the patient to get oblique a little bit, then you can identify the trajectory when you're going in obliquely a little bit. And I think the robot does a really good job of pre-planning that. I've had difficulty actually using it in the same way you use a pedicle screw to place that first dilator in. To me, that's a navigation piece at the moment, not a robotics piece. So I think that's a good point I like your idea of, I just center the disc space. I like your idea of where the implant is from front to back, and then identifying that location over there. So.
Right, and I think you can see it here too.
Make sure you take an X-ray in there, so because the picture on the screen isn't real, right? That's just
yeah, that's right. If you depends how much you believe it. But so why don't we can get X-ray, and I was going to drop the retractor. Here's the retractor, so we should be good. Basically, X-ray.
Yeah, so I think it's important for feel there too, because you really have to tell whether you're in the bone or the disc space when you put that in. Just take a picture.
Yeah, come on in with a picture.
What? Like it was hitting. Yeah, hitting it pretty hard. Yeah, because if you're not in the disc space, no matter what your picture says, you got to find the disc space.
Right.
Yeah.
So to your point, I mean, whereas previously with fluoro, we needed to make it a perfect up and down, laterally positioned, patient.
Yeah.
We spent all that time getting X-rays beforehand, positioning them perfectly lateral, getting an AP that's perfect with respect to rotation of the bed and so on. I still like to do that because that's how I was trained and that's how my brain works, but it doesn't need to be perfect. And the point is I can save a lot of radiation this way in doing it like this. I'm going to say 3-4 is kind of in this space.
Yeah, but I really like the idea of using that for some planning beforehand, not just for the pedicle screw planning. I think
exactly
do that, and then the combination of navigation robotics makes it pretty easy in that spot. I think we used up our 2 minutes. Is that correct?
Right. Can you see the screen? Can you see the X-ray screen there? You guys see that?
Just tell it what it looks like. We trust you.
It looks amazing.
Wow. There you go. See, it's perfect.
No, it does. I mean, if we can rotate that camera so you can see it there, and we kind of move things along a little fast there, but it's really in the position that I want it to be, which is that it's in the posterior aspect of the disc space, and then I would open up the retractor, do my discectomy, and ultimately do everything else that I would do, with disc prep and so on. The other thing I just want to point out real quick is that the instruments that you have with the robot, in terms of disk prep, you have the disk prep stuff? Yeah. So you have the ability to pass the cob navigated. There's a ring curette, there's a rasp navigated. Yeah. The trials are navigated.
I think
which is a good piece. I just think it's a good piece of remembering that we're using planning, robotics, and navigation. We try to work those together rather than just deciding, oh, I'm a robotic surgeon or I'm a, I'm navigation. I think the combination of all of those really help you out when you're doing that, especially in the lateral and especially when you're doing it. So Juan is not a trusting soul. I can
I can tell.
Yeah, and so he's coming in to check on things. And I think, do we have any?
All right, do you want to go AP?
So do you have any questions? Is that what you want to start?
I think we're going to, Noosh, thanks so much. We'll go.